All right, welcome. Today, we're going to build a drug study from the ground up, one that you'll actually need for your exams and, more importantly, for your first day on the wards. We are tackling a big one, amiodarone, a drug that's as much of a lifesaver as it is, well, dangerous. Let's get right into it.
So what's the answer? Yep, it's amiodarone. This is one of those drugs in cardiology that everybody knows and everybody kind of fears. And for good reason. Understanding this drug isn't just about memorizing facts for a test, it's really about learning to respect its sheer power.
Okay, so here's our game plan. We'll kick things off with what amiodarone is, then get into its pretty unique four-class mechanism. We'll talk about why it's a drug that basically never leaves the body, which leads right into its huge risk profile. Then we'll cover the practical stuff, how to be vigilant in practice, and wrap it all up with a really cool iodine-rich pearl.
All right, first up, what is this stuff exactly? Let's break down its official classification and where it fits in our toolbox. So, on paper, amiodarone is a Class 3 antiarrhythmic. And what does that mean? Well, at its core, it's a potassium channel blocker. But honestly, that label, it doesn't even begin to tell the whole story. As we're about to see, it's so much more than that. Clinically, this drug is an absolute powerhouse. It's used for the really scary stuff. We're talking life-threatening ventricular arrhythmias, like VTOC and VFib. But it's also a heavy hitter for managing those stubborn cases of atrial fibrillation. So yeah, you'll see it used everywhere, from the chaos of a code blue to long-term chronic cardiac care.
Okay, so that's what it's for. But how does it actually work? How does it tame these chaotic heart rhythms? For that, we've got to zoom way in, down to the cellular level.
And to really get its mechanism, we have to talk about the cardiac action potential. Remember this? This is the fundamental electrical cycle of the heart. Amiodarone gets right in there and interferes with the very signals that tell the heart cells when to beat.
So here's its main gig, its Class 3 job. It blocks potassium channels. What that does is it slows down phase 3. That's the repolarization, the reset phase for the cardiac cells. By dragging out that reset, the entire action potential gets longer. And here's the magic trick. This extends what we call the refractory period. The heart cell just can't fire again too quickly. And that is how you break the cycle of those dangerous reentrant arrhythmias.
But, and this is a huge but, amiodarone is not just a Class 3 agent. It's often called the Swiss Army knife of antiarrhythmics, and for good reason. Look at this. It has Class 1 effects, blocking sodium channels. It has Class 2 effects, kind of like a beta blocker. And it even has Class 4 effects, blocking calcium channels. It does a little bit of everything. This all-of-the-above attack is precisely why it works so well on those stubborn, life-threatening arrhythmias when nothing else will.
Next up, let's talk about the drug's journey through the body, its pharmacokinetics. And I'm telling you, this part is absolutely essential because it explains why this drug can be so incredibly toxic.
54 days. That is the average half-life of amiodarone after chronic dosing. Just let that sink in for a second. 54 days. We're talking nearly 2 months for the body to get rid of just half of the drug. And as you can imagine, that has massive, massive clinical implications.
So why does it stick around for so long? Well, it's all about this D here for distribution. Amiodarone is extremely lipophilic, which means it loves fat, so it doesn't just hang out in the bloodstream. Nope, it dives deep into your fatty tissues, the liver, the lungs, pretty much everywhere. It basically sets up camp all over the body, creating this huge reservoir. That is exactly why you have to give a big loading dose up front. You've got to fill up that reservoir just to get enough of the drug in the blood to actually work. And it's also why its effects and its toxicities can linger for months after a patient stops taking it.
So, you have this drug that goes everywhere and stays forever. And what does that lead to? You guessed it. It leads directly to amiodarone's most notorious feature, its vast and serious side effect profile. This is the part where you learn why this drug demands our respect.
Okay, there are a lot of side effects to note, but don't worry. For your exams and, more importantly, for clinical practice, there's a really helpful way to remember the key toxicities. Just think of the 6 Ps mnemonic. Let's walk through these 6 Ps because each one represents a major system that can be harmed. First, it prolongs the QT interval, which can risk that terrifying arrhythmia, torsade de points. It causes severe photosensitivity, we're talking wicked sunburns, and that distinct blue-gray skin pigmentation. It can damage peripheral nerves, and then there's the one we all fear most, irreversible and potentially fatal pulmonary fibrosis. Finally, it affects the peripheral conversion of thyroid hormone, which can just wreak havoc on the thyroid.
Given these risks, the contraindications are pretty clear-cut. You absolutely do not give it to patients with severe bradycardia or a high-degree heart block unless they have a pacemaker.
It's a pregnancy category D drug, which means there is known evidence of human fetal risk, and you have to use it with extreme caution in anyone with liver or pre-existing lung disease.
So, with a drug this powerful and this dangerous, how in the world do we use it safely? Well, it all comes down to two things: vigilant monitoring and crystal clear patient education.
And I'm not kidding about the intense surveillance required. Just look at this. Before you even start the first dose, you need a full battery of baseline tests, an EKG, thyroid and liver function tests, pulmonary function tests with a chest x-ray, and an eye exam. And that monitoring absolutely must continue for as long as the patient is on the drug, constantly checking for damage to the heart, thyroid, liver, lungs, and eyes.
As a clinician, these are the non-negotiable points you have to drill into your patient's head. Sun protection is a must. Any new cough or shortness of breath is a medical emergency until proven otherwise. Vision changes need to be reported immediately. And maybe the most important thing is they have to understand that the drug's side effects don't just stop the day they take their last pill.
Finally, let's look at a fantastic clinical pearl. This is one of those high-yield aha moments that directly connects the drug's chemical structure to one of its most common toxicities.
So check this out. Amiodarone's chemical structure looks a whole lot like thyroid hormone. And get this, it is 37.5% iodine by mass. A standard dose floods the body with 20 to 40 times the normal daily intake of iodine. This massive iodine load is what directly interferes with thyroid function, causing the frequent hypo or hyperthyroidism we see in these patients. It's just fascinating.
And this brings us right back to the fundamental question every clinician faces with this drug. The decision to use amiodarone is never taken lightly. It's a drug of last resort, reserved for those critical situations where its benefit in controlling a life-threatening arrhythmia is deemed worth the very substantial and very real risk of toxicity. It is a true high-stakes balancing act.